Hi, and welcome to Steps to Strides and this explainer video with me, Connor Ratcliffe, musculoskeletal specialist podiatrist and senior lecturer. As always, no single source is entirely comprehensive and wider reading is encouraged, as there's always nuance in differing scenarios and presentations. Anyway, hopefully you're going to enjoy these videos and the often chirpier and slightly less verbose than me voiceovers within them. So thanks for watching. Enjoy.
All right, let's jump right in. Today, we're tackling one of the most important skills we use every single day in the clinic, exercise prescription. We're going to break down how you can fine-tune exercise intensity to get the absolute best results for your patients. You know, this is the million-dollar question, isn't it? It's that tightrope we all walk. We have to push just enough to create change and progress, but if we go too far, we risk overload, a flare-up, and a major setback. Finding that sweet spot, that perfect therapeutic window, well, that's what this is all about. Okay, so first things first. Before we can even think about adjusting the intensity of an exercise, we have to know what we're dealing with. We need a simple, reliable way to measure it, to get a baseline. And for that, we have our two go-to subjective tools. On one side, you've got your classic pain scale. This is absolutely essential for keeping an eye on tissue reactivity, making sure we're not poking the bear too much. On the other side, we have the rate of perceived exertion, or RPE, which tells us about the patient's overall effort. Now, the real key takeaway here, especially when you're working with someone in pain, is that using these two together, that's what gives you the clearest picture. So, once we're measuring effectively, how do we actually change the intensity? I want you to think of this like having a toolkit with 6 different dials. You can turn each one up or down to perfectly customize an exercise for literally any person in front of you. And here they are. These are your 6 key variables. You've got reps, sets, frequency and recovery, load, range of motion, and tempo. This is basically our roadmap. We're going to walk through each one, so let's start with the first and most obvious one. First up, reps. This is probably the simplest dial to turn. Want to make it harder? Do more reps. More reps equals more volume, which means higher intensity. Simple, right? But there's a catch, and it's a practical one: time. If you double the reps, you've just doubled the time that exercise takes, and that might not work for your patient's schedule. So, what happens when your patient hits a wall? They just can't squeeze out one more rep in a single go. Well, that's where sets come to the rescue. By adding another set, you can still increase the total amount of work they're doing without pushing them past their failure point. It's a fantastic strategy for breaking through those frustrating plateaus. Next up, we've got frequency and recovery, which are really two sides of the same coin. Think about it. Are they doing this exercise once a day or 3 times a week? Are they resting for 30 seconds between sets or 2 minutes? The basic rule here is pretty straightforward. The less recovery time you give, the higher the metabolic stress and the more intense the exercise feels. Load. This is the one everybody thinks of first. You want to make it harder? Add more weight. More load means more mechanical stress, which is a really powerful driver for intensity. And as clinicians, this is where we get to be creative. Load isn't just dumbbells. It could be body weight, resistance bands, or for a patient at home, it could be a couple of tins of beans or a bag of flour. Let's get a little nerdy with some physics for a second. Remember, work done equals force times displacement? Well, by increasing the range of motion, we're increasing the displacement part of that equation. That means more work is being done and more energy is being used. It's why a deep squat feels so much harder than a shallow one. The muscles are under tension over a much greater distance. Now, tempo. This might be the most powerful and yet most underutilized variable we have. It's not just about getting the reps done, it's about how you do them. By deliberately slowing down that lowering phase, the eccentric, or by adding a pause at the top or bottom of a movement, we can dramatically increase the time under tension for the muscle, and that is a massive stimulus for adaptation. Here's a perfect practical example. You could tell your patient to use a 1-2-3 tempo. That's a 1-second lift up, a 2-second pause at the top, and a nice controlled 3-second lower. See? That simple instruction instantly transforms a basic exercise into a highly specific therapeutic tool that focuses on control and maximizes that time under tension. Okay, so we've looked at all 6 of our dials individually. But the real magic, the true art of clinical reasoning, happens when we start to understand how they all play together. Now, this might sound complicated, but it's actually fantastic news. Because yes, if you crank up the load, you'll probably need to dial back the reps or maybe increase recovery time. This interplay means you have an almost endless number of combinations to work with. It's what allows us to get away from cookie-cutter programs and build something that is truly perfectly individualized for our patient. And now we get to the most important part of all. We can have all these incredible clinical tools and understand all the science, but it all means nothing if we forget about the actual person sitting in front of us, because the most perfectly designed program in the world is a complete failure if the patient doesn't do it. So I want you to run through this quick mental checklist for every single exercise you prescribe. First, do they actually buy into it? Second, can they physically do it with good form? Third, do they realistically have the time, the space, and the equipment? And finally, and this one is so important, do they understand why you're asking them to do it? If you get a no on any of these, that program is built on some seriously shaky ground. And I really want to leave you with this thought. It is so easy to get lost in the mechanics, the protocols, the textbook definitions. But we have to remember we're not just treating a diagnosis on a piece of paper. We are helping a person with a problem. By mastering these 6 variables and by always keeping the patient at the absolute center of our reasoning, that's how we build effective plans that lead to incredible outcomes. Thanks so much for watching.